All right, so when it comes to like vascular patients who have like an exposed graft, is that an automatic take the graft out then, or is there any way to salvage the graft? Really? Because right now, unless, you know, for us, it was always a golden rule: if I see graft, I'm taking it out, at least in the front. So maybe next time I'll send them to you first before taking the graft out. Because take the graft out, the leg is going to be jeopardized significantly.
Salvage.
Yeah.
May I independently confirm Dr. Chow's success with muscle flaps? He has saved, personally, probably 3 legs of my patients. The muscle flap can fix your graft. It's amazing when it works. Love you, Jerry.
So can you tell us a little bit, I mean, I know that, we know that Botox, a lot of people use Botox and things and whatnot. And I've actually been calling you on these patients where I can't do anything and send them to you for Botox injections. Can you expand on that?
Well, Botox works, basically it paralyzes the smooth muscle. That's what it's doing. And when you paralyze the smooth muscle, it's the vessel dilates and you can increase circulation to your toes, your feet, and stuff like that. The problem is the insurance companies don't want to pay for it. Otherwise, we'll be using it a lot more. Unless the patient is willing to pay off the money, or unless the patient is admitted in the hospital and try to sneak that through, it's impossible.
Well, they get admitted for the wound.
By the time we injected it, the building department was even
But Dr. Chow is the only one I know that does the Botox injections in the foot. I know no one else that does.
He's also very viable.
Yeah, absolutely. Absolutely.
I have a guy who, the emergency room, so they put a tourniquet on his finger. Did you see him? And the finger got really black, and we put Botox on it.
Yes.
Or surgery. I don't ask so many questions.
What about an exposed AV graft, for dialysis? For the most part, those, I don't think we can obviously break it. I don't know.
Unless there's no other option.
Right.
But maybe AV graft you can do it elsewhere.
Yes.
Find another source.
Right.
So go through, let's say it's in the elbow. I just take a latissimus dorsi.
Because, you know, in my experience, when I've had an exposed graft and I resect that portion of that graft and I do a jump graft around it, because I didn't resect the whole thing, it's not long before the rest of it, they come back, the rest of it's infected. So in the end, I always just take everything out. And that's how I was trained. It's just, once the graft is exposed, just take everything out. But at least for the ones in the groin, if we can salvage those are great, because that's a mess, and I hate doing that. It's just a mess. Question?
So, Dr. Chow, my question is from an internal medicine standpoint. You know, these patients that I see on these pictures, I mean, they feel like their A1C is like 12. And so, do you jump right in and remove that? Do you have boundaries to say, well, we need to get their A1C down to an age before I'll touch them? Obviously, they have IV involved, they have, vascular involved. And
again, most of these patients, everybody else is already involved. They only call me when there's no other choice. It's sad. I wish I could do that sooner. What?
Enterocutaneous fistula.
They do a lot of anal fissure.
Well, what's that? Enterocutaneous.
Enterocutaneous fissure.
Like from diverticulitis
Or Crohn's.
Why can't you fix it?
Yeah, tell us about that.
Well, we got some jealousy in here.
Well, Phil and I did a big case recently.
You did the case. I took the credit.
We basically took all her muscles apart, took the fascia, just wrapped her stomach, all the guts together in like a dumpling, and then close the muscle, seal everything. And no pain, no nothing else.
Back to work.
It was incredible.
Back to work. Just one.
We will try it. We'll try it.
That was Jerry.
So if we're even like some of these DKs before we go and switch them over to an AK, maybe we should try to see about a flat closure before converting from the DK to an AK. Thoughts?
Yeah, we all, but this limb salvage,
Yeah, it is.
should give us a chance.
Absolutely.
Yeah, I tell you, the gracilis flap, the sartorius flap, it's gonna save your groin grafts 9 out of 10 times.
Absolutely.
Seriously. And your limb then.
Do you have any recommendations, like, did you say all these other adjuncts? After you say give up, maybe we should go forward with flap closure. Do you have anybody, do you have any recommendation of, say, give up on all these
Oh, yeah,
closure?
you know, when the patient's really sick, and some of these operations are long operations. You get bad cardiovascular problems.
So I guess the question is, do you want to see them earlier rather than later?
Yeah, when do you say, I give up?
I have no control on this.
No, I know you don't,
Yeah.
but do you have any recommendations for people in the audience to say, that's the time to say, send them earlier rather than later?
Well, I'm not a wound doctor.
He said that at the beginning.
So after 6 weeks, if it's not healed by 6 weeks, maybe give us an opinion. 6 weeks is good.
Jerry, I like what you said about seeing a wound every 2 weeks. I think that's probably the most important thing is to make sure that the measures you're implementing are having an effect for the patient. And you follow up in 2 weeks, see me again in 4, you're a little suspicious. Once you see him on the 4th week, 6th week, it's not working, you need expert help. I think 6 weeks is fair, but what you're doing is not working in 4, it's not going to work in 8. And wounds will tell you very quickly whether what you're doing is working. That's pathognomonic for this disease. If what you're doing is working, the wound will tell you very quickly. Within 2 weeks or 4 weeks, you know whether that wound's working, whether it's healing, if you got the granulation tissue. You should not be managing a wound 3 months, 6 months. You know right away, you'll know. You just have to be honest with yourself that you need help, you need to get Jerry involved. The patient frustration is unbelievably intolerable after about 6 weeks. They don't like coming back 3 strikes, 4 strikes, 5 strikes. You'll alienate them. Their cousin won't come. They won't refer their aunt. So 6 weeks, get them over to somebody who might be able to help is probably a good idea.
Hey, Jan, just real quick, I know that in the wound, you asked them to come every week versus every 2 weeks. Nothing, I just want to know the.
Dependent upon the patient.
Okay, I just want to know the thought process.
Once every other week, if you're followed by therapy,
No, I didn't.
what do you have?
Sounds good. Thank you.
No less than.
And so to the point of like, if the wound's getting bigger, let's say 2 weeks later, do you refer out right away or like, rather, because it's supposed to get smaller every week?
Physician dependent.
Real nice,
So the problem is, so I'm not trying to add another comment. It's not red light, green light. It's red light, yellow light, green light. So you can see a patient every 2 weeks, but at 2 weeks, if you have a yellow light, so many times what we're doing is we're dealing with what is the wound like today, absolute, do I continue my treatment, or do I need something more aggressive? You've got a guy here in the community who pretty much knows A to Z from minimally invasive to maximally invasive. I don't think you need to be afraid. You're not sending the patient there for a muscle flap. You're not sending the patient there for some gigantic island flap. You're sending them to Jerry or to a plastic surgeon for reassessment, reevaluation, and for consultation. So I don't think you have to always think of something as, I'm working with these wound care products and now it's surgery. The yellow light is where they need to see the surgeon, not when everybody agrees nothing's working. When you're not seeing progress, that's the time to come in to try to avoid that big surgery 3 months later.
So hard to, limb salvage is different. You gotta be passionate about limb salvage to really be successful. And be willing to go full.
Yeah, Dr. Grassi said, you know, it takes looking at the plan of care, the plan of care changes, and if you alter it and have more aggressive care, you know, it might turn around completely. You know, you see the patient in 2 weeks, yeah, it might have gotten bigger, but then you completely change everything. You didn't really consult out or not, you know, to try something different first. You want to maintain your
Now the other way around, on a few occasions where Dr. Chow is seeing patients with venous ulcers, maybe I think it was a meeting ask. It says, hey, check some venous issues and see if it doesn't heal. And then they have vein problems that I fix, that the patient gets to. But the purpose of all this is again, is to bring quality of life back to the patient, right? You gotta keep them independent, happy, educate them. You know, but it takes a team effort. It takes podiatrists, it takes general surgeons, it takes internal medicine, it takes plastic surgeons, it takes everybody to work together. And it was nice, is, you know, Dr. Chow has my number, I have his number on speed dial, you know, podiatrist, Dr. McDermott, call me like that. He's your patient. I'll get the patient in either that day or within 24 hours. I don't wait. If I get a call from the doctor, I get him in right away. Because I know that time is of essence. So, but it takes a team effort to really be part of the limb salvage and to salvage the limb, and at the end to get quality of life back to this patient. So, thank you all for. You guys have any questions real quick for Dr. Chow? Thanks, Dr. Chow. And thank you all for your